Hey, good morning, everyone, and welcome to Your Nurse. I'm your host, Vic Sinise. Glad to have everybody on board the show. If you're watching us live, great. Enjoy the show. We're available on all those formats. And if you have any questions, you can always use the comment box to send us your questions. If this is your first time joining us, be sure to check out our website at euronurse.com, the best place to go to learn more about the show. It's also the best place to go to find out about our past episodes, and we've got 87 of those episodes. Hey, you want to listen to us in your car? No problem. Go to our EuroNurse Plus area where you can go ahead and check out our audio podcast and listen to us anytime you want. All shows are converted to audio podcasts so you can listen in your car. If you're a patient and you're watching this show, well, you may learn a few things. That's great, but also check out our europatient.com site. It comes on every Saturday after this show at 10:30, and we have a new topic. This week, we're going to talk about the prostate surgery for the old gold standard called the TURP. Everything you should need to know about that will be talked about. So join us after this show. And if you don't get our newsletter, what are you waiting for? Go to MailChimp and check us out. Go to our website, and utilizing MailChimp, you'll be able to sign up securely. You don't have to worry about sharing your email. You just put it in there, and it never gets sold to anyone. This week, I'm really happy to have a repeat speaker, Dr. Arpeet Shah, who's going to be talking about Sonablate HIFU, which is a new treatment for prostate cancer. So we're all looking forward to learning a little bit more about that. And with that, I'm going to go ahead and bring in our experts right now. Welcome to the show, everybody.
Good morning.
We have Lori and Dr. Shah joining us. Again, my name is Vic Sinise. I am the host of the show and the producer. Been involved in urology for the last 40 years, and this was my way of giving back. We kind of open it up if we want to have an interesting story or something surprising to talk about, or maybe just let people know what's going on in our life. So I'm going to share a story with you guys. This is what happened new in my life. Just had another grandchild. This is my baby number 10, little granddaughter, Michaela. And the one standing next to me looking at her like, hey, that's her big sister when she does not want to share grandpa. So, but that's my exciting news. Now I got 10 grandchildren. 8 of them are granddaughters. Oh boy. All righty, Lori, go ahead and introduce yourself.
Hi, my name is Lori Atkinson. I'm a certified urology registered nurse. Been in urology for 25 years now. I currently work for a urology practice in Winfield and Geneva, Illinois. And I might top you in the long run there. I got 5 kids. I have 4 grandkids already. Let's see how far that goes. And By the way, today I'm going to the Cubby game. So go Cubbies.
Hey, it should be a nice day for Cubs.
Yeah.
It's nice and sunny here.
Playing the Dodgers too, right?
Yep.
Yeah. Did they win yesterday, or?
I believe so.
The Open, yeah.
I believe so.
Sure. All righty.
All right.
Now, Dr. Arpeet Shah, go ahead and take it away.
Well, Vic and Lori, it's a pleasure to be here today. I'm only on my second child, but I have a 3-year-old and 6-month-old, and so certainly we are busy with that. Yeah. It's a pleasure today to be talking about Sonablate HIFU and its new treatment for prostate cancer. So I'm excited for our discussion.
All right. And let's bring up your slides here.
So funny story about HIFU. We're talking about this as it's a new treatment for prostate cancer, but it's been around for decades. And in fact, the first urology procedure I ever saw was HIFU. It was not for the treatment of prostate cancer. It was actually for the treatment of a renal mass. And that's fallen out of favor as there's, more and more data. But this is a technology that has been around for a long time. And specifically, HIFU for the treatment of prostate cancer has been around for a long time. But it has just kind of been approved from an insurance basis, which is why we see a real surge in its usage. So today, we're going to talk about a brief introduction on Sonablate HIFU for the treatment of prostate cancer. And this is a technology that we are offering across the country, but, locally in my area in the southern suburbs of Chicago. So what is HIFU? So HIFU stands for high intensity focused ultrasound. And it's basically the use of ultrasound energy to ablate which means destroy by the means of heat, targeted tissue within the body. And like I said briefly at the introduction, it's not only used for prostate cancer. This has been used for the treatment of solid tumors of the bone, brain, breast, connective tissue, esophagus, kidney, liver, and pancreas, and prostate. So it is utilized in a variety of cancers and for the treatment of those cancers. So how does HIFU work? And so the best analogy that I could give you is that of a magnifying glass. So just as a magnifying glass can focus the sun's rays to burn a leaf, HIFU focuses ultrasound waves to ablate tissue. And just as the sun's light between the magnifying glass and the leaf will not burn your hand, the HIFU ultrasound waves don't burn the tissue between the transducer and the focal point. So you're basically using these ultrasound energy waves and focusing them on a point of tissue that is at a separate distance, and all the tissue in between those 2 points is not really affected. And, in terms of the treatment for prostate cancer, we used to, decades ago, we would only do surgery or radiation and for the treatment of prostate cancer. And those are still considered the gold standards of treatment for prostate cancer. But there are downsides of it. With surgery and radiation, you're doing whole gland treatment, which can cause significant side effects, specifically urinary side effects and side effects with erectile dysfunction. Like I said, it's still considered the standard of care, but over the years, we have realized that not everybody needs whole gland treatment or needs surgery or radiation for the treatment of prostate cancer. And really, over the last 10 to 20 years, the concept of active surveillance, which is completely on the other side of the spectrum, has really taken favor for a lot of prostate cancers. In fact, it's probably appropriate for about 40% of patients with the diagnosis of prostate cancer. And active surveillance, it involves just watching the prostate cancer, making sure it doesn't grow or change. And if it does grow or change, kind of moving on to more aggressive therapy. The downside of active surveillance is, there's a significant psychological side effects of just, having to have this diagnosis of prostate cancer and watching it. Sometimes people don't. People find that very anxiety provoking. And then obviously there's a concern for disease progression, especially if patients are lost to follow up. And so over the last 5 years, really, the idea of focal therapy for prostate cancer has really taken off. And so the idea of focal therapy is we identify the area of the prostate where there is cancer. You treat that area and you leave the rest of the gland behind. And so the benefits of focal therapy is that you can treat the disease, but minimize the side effects, specifically of erectile dysfunction and urinary side effects. And focal therapy is not appropriate for all patients, but it is probably appropriate for a significant portion of our patients that with the diagnosis of prostate cancer. So when we talk about Sonablate HIFU, really what I'm utilizing it for in my practice right now is targeted focal ablation. It is approved for whole gland treatment. So, on the surgery radiation spectrum of this graph. But I've been using it more in the middle of targeted focal ablation. And so the goal of focal therapy is to reduce the side effects from any therapy for prostate cancer, but still maintain disease control by targeting the specific known areas of disease. And there are actually 3 platforms out there for focal therapy using ultrasound. This is one of those that are available. And the picture on the screen is the picture of the setup. It's a very easy kind of mobile apparatus. This can be brought into hospitals or surgical centers and really do not take up a significant portion of space within the operating room. What's involved is you'll see the transducer, which is very similar appearing to a transrectal ultrasound. You'll have the monitor, and then you'll have the machine, as well as kind of a cooling tray. And really, this is all you need. The procedure is not done completely sterilely. It doesn't have to be done completely sterilely, just like a prostate biopsy is not completely sterile. And really, there's no incisions. You just do the whole procedure using the transducer, which is placed into the rectum of the patient. So, essentially there's three steps in this. So the first step involves putting the transrectal ultrasound and probe into the patient's rectum and identifying the prostate and making sure that everything is kind of collinear and set up where the prostate is completely mapped out. The second step involves the physician and the Sonablate tech to use the ultrasound to map out the zones of the prostate gland that need to be treated with HIFU energy. And we can integrate MRI data. So just like we can do an MRI fusion biopsy, we can use the same MRI pictures to overlay those pictures with the live ultrasound with Sonablate and really pinpoint the location of a lesion that might have been seen on an MRI and to make the plan to treat only that lesion. And once you've kind of mapped everything out, the physician will start the procedure and really start delivering the HIFU energy to create small overlapping lesions in the prostate. So you're ablating bit by bit little segments of the prostate gland and the areas that you targeted. And each kind of zone of ablation is about the size of a grain of rice. And so you're kind of breaking down the prostate into little grains of rice and going through your plan and ablating the tissue. The big thing is that you ablate the tissue that needs to be ablated, and then the tissue that does not need to be ablated, such as the area where the neurovascular bundle might be, where those are where the nerves that control erections go along the prostate are not affected, and then you spare the areas around the urethra. So what makes Sonablate HIFU different is one is you can use the MRI fusion technology. So I think that's really nice. We do MRI fusion prostate biopsies all the time. Why can't we use that same technology when we treat the prostate cancer? And so you can do that. The second thing is you have very pinpoint accuracy while sparing untargeted tissue during the ablation process. And what I think is the most interesting thing about Sonablate is the computer program will analyze how well that tissue that you're ablating has been treated. So that third picture that you see on the screen, you see a series of yellow and orange and green boxes. And those are each grain of rice, that you're treating in the prostate. And it'll give you real-time feedback in terms of how well that tissue has been ablated using visual characteristics and changes of the ultrasound. So this kind of even goes over my understanding of computer programming, but essentially it will analyze how the tissue looked on ultrasound before the tissue was ablated and then after, and make sure that tissue has changed sufficiently enough that it has been treated effectively. So you can identify areas that have been undertreated and retreat those areas at the moment of the ablation, which is really neat. So like we talked about, this is a customizable treatment to meet the individual patient needs. So it allows for customizable treatment based on where the cancer is and what the goals of the patient are and the physician in terms of treatment. And so it allows a urologist to tailor the treatment plan and address the individual needs of each patient, avoiding critical structures like we talked about that affect urinary continence and erectile function. And it provides this real-time feedback while you are treating this, and that's the tissue change monitoring feature, which I have another slide about. And so It has been approved and it's utilized for focal treatment. So if you have a lesion that is visible on MRI or ultrasound, you could just treat that focal area. You could do hemigland treatment. So let's say all the cancer that you have found is just on one side of the prostate, then can we spare the other side of the prostate potentially? And so you can do hemigland treatment. And then it is also used for whole gland treatment, where if you have diffuse prostate cancer, you can use this therapy. I typically do not use it for whole gland treatment. In my opinion, if you need whole gland treatment, I tend to lean towards the more standard treatment options, which are radiation or surgery. So this is that slide again on tissue change monitoring, which I think is really the coolest part of the Sonablate technology. So this is live measurements of tissue change using ultrasound imaging, and it's presented on the screen to the tech and the physician while the treatment is in process, and it tests for adequacy of tissue treatment change after ablation. And so what this basically allows us to do is if that picture that you see in the middle was the area that we wanted to treat, all of those green boxes have been undertreated. And this allows the surgeon to re-ablate those specific areas of tissue that may have not been adequately treated. And kind of what we talked about, just the procedure itself, it starts with the ultrasound going in transrectally. We then utilize the ultrasound to map out the zones of the prostate that need to be treated. Then once we have completed the planning, the procedure will start and the HIFU energy will begin to create small lesions in the prostate. Throughout this time, not only are we looking at the prostate and making sure that the tissue is changing appropriately and being ablated, but we also have a series of measurements in terms of how much heat is dissipating to surrounding tissue, such as the rectum. And so if at any point we feel like the rectum is heating up a little bit too much, meaning that there could be some, potential risk of injury to the rectum, then we would kind of stop the procedure, allow the rectum to cool down, and then restart the procedure at that time. So we are monitoring about 20 things at once while this procedure is going on. So we are making sure that we're treating the tissue that's needed to be treated and leaving all the other stuff behind. And then we'll use the TCM feature to for immediate feedback of how well we've treated it and retreat areas that need to be retreated. We've kind of talked about this. This is radiation free. This is healthy tissue sparing with minimal side effects. We're going to go through some of the data and of what we know of the benefits of this procedure and kind of what the outcomes are. How does it work in terms of flow? So it is a 2 to 3 hour procedure that is done with anesthesia, general anesthesia. We want the patient to be completely still during this process because we are trying to be very precise. So if we cannot allow for any movement of the patient during the procedure. This is an outpatient procedure, meaning the patient goes home the same day. They do have a catheter, and we'll talk about catheter time, but usually it's about 3 to 7 days for my patients. They do not require any really pain medications, specifically narcotic pain medications. I do not give anything like that. I do give some Toradol, which is an NSAID, and they can take some Tylenol as needed. But really, there is minimal pain with this procedure. And most patients can resume a completely normal lifestyle once the catheter is out. So I don't really have any restrictions in terms of physical activity or exercise after this procedure once the catheter is out. And the idea is, once again, lower side effects. And it is known to be a repeatable procedure if necessary. I have not used it as a repeated procedure. Usually if I believe that if you have a cancer, you've had one therapy and you have failed it, you should probably look to a different form of therapy. But that's just kind of my bias and how I think about it. Let's go through a little bit of the clinical data. I certainly don't want to put too much emphasis on this, but we do need to know there is pretty good data on this therapy. So this was one of the main studies. It was over 1,300 men with non-metastatic prostate cancer who were treated with HIFU, and this was a multi-institute experience, and there were 15 years of data, and the big thing was that metastasis-free survival and prostate cancer-specific survival at 7 years was 100%. So if you got this therapy, you were not going to have metastasis or die from prostate cancer at 7 years. The 7-year failure-free survival in intermediate and high-risk prostate cancers was 68 and 65%. And so for a majority of patients, they did not require more therapy after they had this within the first 7 years. And adverse events were very low. It happened in less than 1% of patients. This was another study. This was about an 8-year study that compared patients with prostatectomy versus patients who are getting HIFU and or cryotherapy. So essentially focal therapy versus radical prostatectomy. And essentially the oncological outcomes over 8 years were similar between focal therapy and radical prostatectomy in patients with non-metastatic, low or intermediate risk prostate cancer. So it's certainly a safe form of treatment for those patients and equivalent in terms of oncological outcomes at 8 years. You know, there's been several studies that have come out and clinical data for targeted HIFU procedures. So these are the focal HIFU procedures. And, you know, this is a table kind of summarizing all of them. But I just want to highlight certain things from what the studies have shown. And they've been relatively consistent amongst the studies in terms of what they show. So we are treating patients with clinically significant prostate cancer. So I'm not utilizing this for my Gleason 6 prostate cancers. I tend to favor those for active surveillance. But these are Gleason scores of 7 or higher in a majority of times in these studies. So, you know, anywhere from 69 to 89% of patients in these studies have clinically significant prostate cancer. What are the chances of needing salvage procedures, meaning procedures after HIFU because of a recurrence? Well, it ranges from 7 to 13% in these studies. These studies have various follow-up ranges that go from anywhere from 2 years to about 5 years. So, you know, in 10 years, those numbers are going to be higher. And I certainly will quote patients of a higher risk of needing salvage therapy. But this is really where the cool parts of these studies comes out. So what percentage of patients retain continence? You know, it's anywhere from 95 to 99% of patients who get focal therapy. And so those numbers are exceedingly lower in prostatectomy patients or even patients who have radiation therapy. And the other thing is what percentage of patients retain their sexual function. And it's a little bit cut off there, but it's all in the mid 80s, which is once again much more better than surgery and radiation. So you're really sparing the tissue that preserves continence and sexual function. A little bit about my experience. So I've been doing this not that long, quite honestly, you know, for about 6 months, but that has largely been, you know, due to just the insurance has now been paying for it for the last 6 months. And so before then, most patients were not getting this because the out-of-pocket costs were too high. Who do I offer this to? So I offer this to my patients who might have had progression on active surveillance, patients with small tumors or unilateral disease. And then if I have specific referrals of appropriate patients who are interested in HIFU. So I sometimes we'll have a colleague of mine send a patient over and said, hey, this guy really wants HIFU, and can you talk to him about it? Realistically, I'm very, very specific in who I offer this to. And I know I can offer it to a higher population of people, but what I offer it to is if you have clinically significant prostate cancer that needs treatment, that there is a lesion visible on MRI. That lesion, when targeted and biopsied, is positive for the clinically significant cancer, and that the other areas of the prostate that are sampled on biopsy do not have significant disease. So if you hit kind of all of those criteria, I'll be mentioning HIFU. But if not, I'll mention it, but I really will kind of lead a patient towards a different treatment option. And that's because when we're talking about new therapies for cancers, I like to be very conservative until we have longer term data and we know kind of what's going to happen. What's my staging protocol? So obviously patients will have a PSA, they'll have a multiparametric MRI of the prostate, they'll have a targeted biopsy of the region of interest and a standard 12-core random prostate biopsy. There has to be confirmation of unilateral or focal disease. I will counsel patients on all their treatment options and only offer HIFU to patients who are appropriate. And then I emphasize the risks specifically to focal therapy and the possibility of needing retreatment, which I think is higher than your conventional surgery or radiation. And I also like to emphasize what success is. And we can have a discussion on this later on, but it's very important to define what success after therapy is. Your PSA is not going to go down to 0. It's not like a prostatectomy. And so we are looking for PSAs that drop but remain stable and no new or signs of progression on MRI. So post-procedure, like we talked about, catheter 3 to 7 days. I have not had any catheters that I've needed to keep over a week. They've all been done as an outpatient. I've had no major complications. Continence is similar to the national outcomes, 98%. I mean, I have not had any patients that are incontinent after this procedure. And sexual function is similar to national outcomes of 85%. My follow-up protocol, PSA and MRI at 6 months. And then I do a PSA every 6 months and an MRI for cause thereafter. So if the PSA is rising, then I'll do another repeat MRI. I don't repeat a biopsy unless there is cause. So unless the PSA is increasing or the MRI is showing something new or something growing. I've had no HIFU retreatments to date, but I expect anywhere from about a 7 to 15% chance of needing further therapy for my HIFU patients in the first 3 to 5 years based on the national data. And that's kind of what I tell my patients. And we're doing a very good job of prospectively tracking our outcomes to making sure that they are consistent with what the studies tell us they should be. That's kind of my presentation. We do have 3 urologists in my group who are offering this procedure, Dr. Aaron Berger, Dr. Rajesh Patel, and myself. And so if you need any more information on this procedure, you can certainly visit sonablate.com or visit our website to make an appointment if you want to talk about this further.
Great. That was a great presentation. A lot of interesting information out there. So we'll open up to questions. If anybody from the audience has questions, use the comment box to send those. Lori will pop those up on the screen for us. I'm going to start out. So this kind of, to me, seems very similar to cryotherapy. Would you say that?
It is in concept. So cryotherapy has been used for focal therapy for prostate cancer for decades. The difference is that I think it's more precise. And certainly has a much lower chance of erectile dysfunction than cryotherapy has. So cryotherapy, one of the downsides is that the risk of erectile dysfunction is very high. So I think we're really reducing that chance of erectile dysfunction or, freezing and causing damage to the urethra as well. So I think the side effect profile will be less. I also have heard anecdotally that treatment after a failed HIFU is much easier than treatment after a failed cryotherapy when it comes to surgical management. So much less scar tissue around the prostate, allowing a much easier dissection and a lower risk of any damage to surrounding structures during prostatectomy after failed treatment.
Yeah, and my follow-up would be, and I know you haven't done a lot of these, but the serious side effects like we sometimes saw with cryotherapy, like fistula formation, rectal fistulas, etc. Has that been in the literature at all, or?
Yeah, so it's been in the literature. It's reported as 0.5% of significant side effect, and that includes rectal fistula, damage to the rectum, or any surrounding structures. So I think it is very low. And as this technology continues to evolve, we're going to have continued improvements in being able to monitor the rectum while we do the procedure to make sure those things don't happen. But to date, I've not had any of those complications.
And Lori, do you have any questions before I hog all of them?
I had a lot of questions, but you answered them kind of towards the end. But I did have one question. Are you still able to perform procedures for BPH afterwards, or even during the procedure?
That's a great question. I will say absolutely you can offer kind of any of the therapies for BPH afterwards. I don't think that there are any restrictions. Now, there might be some insurance restrictions that come with any BPH procedure that you have to follow. But from a technical standpoint, I don't think it would be an issue. And most of the time, you are sparing the areas where there's BPH. The prostate cancer tends to form in the periphery of the prostate versus BPH in the central zones. And if you're utilizing HIFU for focal therapy, you're treating that peripheral zone where the cancer is and really not affecting the BPH at all. There are some treatments and some people who would consider doing focal therapy and treatment of BPH at the same time. I don't really do that or offer that because I would like to see how well their prostate cancer responds to therapy before we're subjecting patients to another procedure there that might impact their choice in subsequent prostate cancer treatment or affect the outcomes of subsequent prostate cancer treatment. So we certainly know that after BPH procedures, radical prostatectomy can be a little bit more challenging, and there might be higher rates of urinary incontinence or erectile dysfunction if you've had a BPH procedure. So I usually like to say, let's deal with the prostate cancer. Let's make sure you respond to that appropriately, and then we'll really tackle the BPH.
Thanks. I had one more question. How about bleeding afterwards?
None significant. I'll tell you that the catheter that we put in at the beginning of the procedure, after the procedure, the urine's crystal clear. So we've had no rates of transfusion, hematuria, or readmission after this procedure for any of my patients to date. Could it technically happen? It could, but I have not seen it.
Great, thank you.
And where are the heat monitors for this? Is it built into the probe? Is there a catheter with the heat monitor for urethra?
This is kind of the neat thing. It's not specific temperature monitors. It is using how the tissue looks on ultrasound and the pixelation quality change in terms of how bright it looks on ultrasound as a surrogate for heat. And it's also a surrogate for how well the tissue is ablated. So you're not having kind of a temperature probe in the traditional way, but you're probably picking up things much more accurately and in areas where a temperature probe could not be, which is very neat.
Now, the one thing I noticed is your time for the procedure, 2 to 3 hours. And I know this is taking little pinpoint sections. Is that for like a small nodule? Because you had mentioned that's really who you're focusing it on, is somebody you pick up on like an MRI nodule that you can actually aim at.
Yeah, so I've done it for the small points, let's say an MRI um, lesion that's like a centimeter that you're treating.
Mhm.
The ablation time is much less. So, but the planning time takes a little bit longer. So I'll tell you that usually these are pretty consistently being 2 hours, despite the size of the lesion.
Mhm.
So if I'm doing a hemigland, which I've done, you don't have to be the planning step of this procedure is easier and takes less time, but the
Mhm.
ablation takes longer because you're ablating a larger volume of tissue. Versus if you have a specific lesion, the planning time takes a significant longer time, but the ablation time is shorter. So it all ends up being about 2 hours.
Yeah. And each of those little ablation sizes of a rice, how long does it take for each of those to occur?
So you can go there are kind of two power modes, and you can change the power mode live during the procedure. So if you go to a faster power mode, it can be as little as 7 to 7 seconds, and then kind of the slower power modes might take 10 to 12 seconds. So um, each grain of rice is taking that amount of time, and
Yeah.
it's a lot like everybody says it's a lot like flying a plane, where you're not actively doing a lot of things, but you are
Mhm.
consistently monitoring like 5 or 6 different things, and your tech is also helping you monitor things. So
Yeah.
you're kind of constantly talking to each other during every step and every second of the procedure, reviewing the temperatures, reviewing the ablation, looking at the TCM. I mean, there's several things you're looking at kind of at once, monitoring everything.
And how's your patient feedback been on this? What are
Really
patients saying
fantastic. I
post-op?
mean, really fantastic because they get back to their normal life very fast. As soon as the catheter is out, I mean, I have patients playing golf. I have patients, taking vacations, um, and really no significant issues. I'm very conservative. I tell my patients that you're not going anywhere for the first 4 to 6 weeks after this procedure. But I've had a few patients who've snuck out and gone on a cruise or a vacation after this, and they come back and they say, "Hey, doctor, I did all this stuff and I was perfectly fine." So um, the patient feedback has been really great. It is really important. Patients are very happy because the treatment is so easy. But it's, another
Mhm.
very important thing to mention and to make sure that your patients understand is the definition of success. And I know I kind of briefly talked about this, but the definition of success after focal therapy is much different than the definition of success after radical prostatectomy or whole gland radiation therapy with or without hormone therapy. So your PSA is not going to have a significant drop. It's not going to go to zero like prostatectomy. It might just be that the PSA stays the same, right? It doesn't continue to rise. And so, a patient might come in and say, "Well, why is my PSA still high? I thought I treated this." And the
Mhm.
answer is because you have the entire rest of the prostate that wasn't treated that's still making PSA. And so, or if you get an MRI, you might still see the spot, but maybe the spot hasn't changed in size. It hasn't grown. Hopefully you don't see a spot, or hopefully it looks like that spot
Mhm.
has been treated on MRI. But MRI reads are subjective at times, and we also, we are looking for a lack of progression rather than a complete response to therapy when we're talking about focal therapy. So the definition of success can be challenging, not only to your patients, but if I do a HIFU on a patient and I have another provider within my practice see the patient during any point of follow-up, they need to be aware of what really success is and what success isn't, so the communication is consistent, and we're triggering further workups and further treatment for the appropriate patients.
So what would be your typical follow-up be? Repeat PSA in something or
Yeah, I do a PSA, kind of what we talked about. I do a PSA and an MRI at 6 months.
okay.
And then I'll do a repeat PSA every 6 months after that. and typically, and sometimes I'll do 3 to 6 months, but depending on kind of the anxiety of the patient as well as kind of how aggressive the disease was. But typically 6 months PSAs, MRI at 6 months, and then an MRI or a biopsy for cause. The PSA is going up. The MRI shows a lesion that is new or is growing. Those are the reasons why I'll do a biopsy. But if the PSA is staying flat and the MRI does not look any different, then I'll just use PSAs for follow-up. We're
Gotcha.
still seeing these patients, 5 to 10 years after treatment. So it's very important to have long-term follow-up because we know that there is a failure rate with this therapy, and it's very important to be very upfront with your patients with that you're choosing a therapy that will work about 85% of the time, but 15% of the time within 5 years, you're going to need more treatment. And so it's very important that you follow up for a long period of time. And then when and if you have the news that you need more therapy, that they're not surprised.
And last week's discussion was about PSA, and it's overdiagnosing cancers, etc. But one of the things we got into was all these other variations on PSA, like free PSA, biomarkers, etc. Do they play any part in your follow up, or just the PSA and MRI?
So I think in things like ISO PSA or EXO have not been really studied in the post treatment or the active surveillance models, really. They are actively working on those studies. And so I really don't use those at this point post-treatment. I just use standard PSA. And
Okay.
I really, and I use MRI because these patients that I'm treating with focal therapy, they have spots visible on MRI. So I think that's kind of the best test that we have for it.
Yeah, makes a lot of sense. Good. Lori, you have any other questions? Were there any questions from the audience?
No questions, but Katie said excellent presentation and new information. It's new information for me too. I just had a patient recently say, can't they just take that piece out? Well, this is kind of another option,
Yeah.
for that.
Yeah, focal therapy has really exploded over the last 5 years. It's included in many guidelines for prostate cancer, and there are several different technologies that are currently being investigated for the treatment of focal prostate cancer. In fact, the company that originally made Resume, which is the water vapor therapy treatment for BPH, is utilizing a similar technology to see if they can use steam to focally treat prostate cancer. There's also some talks about aquablation and Procept using a similar type of therapy for the treatment of focal prostate cancer. And then outside of Sonablate, there's something called TulsaPro, and there's another focal therapy platform that is used for HIFU. So it certainly has sparked the interests of patients, physicians, and entrepreneurs across the country.
Yeah. Almost kind of seems like how breast cancer originally, when it was first diagnosed, you'd find a lump and they did a mastectomy, entire removal of the breast. And then now, same thing with prostate gland. We're finding, little nodule that contains prostate cancer. Radical prostatectomy was a treatment. Then blast the whole thing with radiation. Now we're trying to focus in on that nodule again. And I think that we'll probably find that in the future, that's going to be the key to success.
Yeah, I think that's kind of been the trend, is that unfortunately prostate cancer is always following the tails of breast cancer and uterine cancer in terms of treatment. And so the treatment for breast cancer is very precise and uses a variety of genetic testing to dictate treatment, and precision therapy is kind of the hot word for breast cancer, and prostate cancer is hopefully catching up with that, so we can offer our male patients with prostate cancer kind of the same precision therapy that a lot of women get for breast cancer.
Yeah. Oh, great. This has been a great discussion, and I hope I'll be able to convince you to come back on the program maybe in a year from now to fill us in on where we're at with this. And
Yeah.
it's it's amazing for me just to see how much things changed in, my short career. Well, short career, 40 years, but prostate BPH therapies have become now minimally treated, and prostate cancer, which was radical, is now becoming minimally treated. And all these things are great for patients because, as somebody who, as a nurse, we tend to see a lot of the side effects: incontinence, erection problems, etc. All those things go down as we minimize what we do. So it's really a great thing. So
Yeah.
enjoying our talk. I'm going to put a commercial in for next week's show.
Circumcision is a surgical procedure that involves the removal of the foreskin from the penis. It has been a subject of considerable debate regarding its risk-benefit profile. Proponents argue that circumcision offers various health benefits, including a reduced risk of urinary tract infections, sexually transmitted infections such as HIV, and penile cancer. Additionally, some studies suggest that circumcision may lower the risk of certain genital conditions like phimosis and balanitis. Moreover, cultural and religious considerations often play a significant role in the decision-making process for circumcision. Join us next Saturday at 9 a.m. Central Time to learn more on uronurse.com.
So yeah, join us next week. We're going to talk about circumcision and, some of the, questions, how it's done on children, how it's done on adults, and I should say infants and adults, and should we even be doing it? So be interesting to join us for that. Hope everybody has a nice weekend and enjoy this sun that's coming out and the better weather. And hey, it's spring, I believe. So we'll see you all again next week on uronurse.com.